everybody, and welcome back to another episode of GU Cast. Renu, how are you?
I'm good, Declan. How are you?
I'm fine. What have you been up to?
Oh, I've been travelling. I was in Malaysia over the weekend. Oh, it was fun. It was nice to get out of wintry, cold Melbourne into hot, humid Malaysia.
Holidays or work?
No, it was work, actually. A fantastic meeting. It was their inaugural prostate cancer preceptorship. Just like, we run our ANZUP rapid fire preceptorships here. They're very popular, very well attended. So they, Professor Maniz Assad and Dr. Wei Xian Yo, organisers. They led the convening party, and it was fantastic to mix and mingle with trainees from all different disciplines. Medical oncology, radiation oncology, urology, radiology were all kind of featured there. And Nick James was there. Hi, Nick.
Yeah.
Hope you had a safe trip home. So it was really fun.
And it's not too far up the road, by our standards at least. You can hop on an overnight flight and get there in 7 or 8 hours with not much time.
Not miss a day of work, really.
Yes, and you didn't. That's why you're back at work doing lots of surgery. Good.
So good fun.
No, I've been working. I think I've done 6 or 7 prostatectomies this week, and lots of
holding up the fort.
Yeah, and lots of metastatic prostate cancer this week in the office as well, which is we're used to seeing a lot of localized cancer in Australia, quite heavily screened population, but then you get 3 in a row of these like really bad metastatic cancers, and
definitely coming from Malaysia, they definitely see a big volume of metastatic prostate cancer diagnoses, and it's nothing like we would see here.
Yeah, it's very sobering, by the way, for those of you out there in the first world. When you travel out here to Southeast Asia and you stumble across countries like Indonesia, for example, just up the road from us here, population of about 200 million people. Average presenting PSA at diagnosis about 200 as well. And the main challenge up there can be, for example, access to getting a bone scan in many hundreds of islands that don't have a bone scanner. So different worlds. But so what are we talking about?
We did talk about the other huge meeting that was going on around the same time, which is ASCO.
ASCO, yes, the world's biggest.
You didn't feel like going this year, Declan?
Man, the thing... ASCO, I mean, it's a very important oncology meeting.
It is.
There's about 45,000 oncologists
Chicago is taken over.
It is. And Chicago is a great city. That'd be one good reason to go there.
Yeah.
But the problem for a simple urologist like me is there are no videos of surgery or talks about MRI scanning or PET scan. It's all Kaplan-Meier curves and trials and protocols and translational, which is very important in oncology. But for this simple urologist to fly 24 hours at great expense over there, I just can't justify ASCO. Yeah.
Well, and all the more reason not to, because now we have our team who go out there and give us the highlights, which is what we're going to do today.
We're going to get the ASCO highlights even though we weren't there. And but do you want to introduce your friend and guest who's joining us?
Absolutely, yeah. So we are joined today by Dr. Marty Schoen. He is an assistant professor from the University of St. Louis and the St. Louis VA Medical Center, and my fellow PCF young investigator. Marty, welcome.
Well, thank you so much for inviting me to talk a little bit about ASCO, and great to be on GU Cast for the first time.
And Declan, maybe I've poisoned his mind over the last few years, but he's a big fan of GU Cast.
Is he?
He is. Look at him. He's wearing our T-shirt.
Check it out. If you're not listening, Marty's there. So how did he deserve a GU Cast polo? They normally get it after they've been on the podcast.
This is true. Marty's a unique one, but I don't think he's ever missed an episode.
Yeah, no, I know you're a great fan. Thank you so much. And I saw him sending photos of his GU Cast water bottle on the ASCO steps. I've got one here in the audience. But yes, you too could have a GU Cast water bottle, but one of them, we didn't make it, but the bottle made it to the bottom of the famous ASCO steps.
The famous
Marty.
photo
there
that you take.
He's got it.
There you go. And we loved it. And it accompanied you to many places within ASCO, and we'll get just a bit of a rundown of some of the highlights. Did you have a good trip?
Oh, yes, it was great. It's wonderful to meet colleagues in a great city, and also to learn about the newest science so that we can take care of patients just a little bit better every year. So it's fantastic.
And, we were talking offline before, Marty, big meetings like this, it's not just about the science that you learn, but it's an amazing opportunity to network and, develop new research ideas. Lutectomy was kind of came about in an Irish pub somewhere, didn't it?
No, it didn't. You're making up stuff now. Just that stereotype. Excuse me, Dr. Eapen. Yes. I think it was in a pub in Shanghai, though. Yeah, myself and Michael Hoffman were there.
It was an Irish pub in Shanghai.
But the point is face to face.
Absolutely, face to face meetings are great opportunities for this kind of.
I agree with you.
These kind of ideas to pop up.
Yeah, and I suppose that's why it is still a very important physical meeting, but it's also important to have things like podcasts and newsletters to bring the headlines to the rest of the world who didn't make it to Chicago. And so that's why we're delighted to have Marty on. And we were just chatting beforehand to say it didn't seem or feel like down here in Melbourne that it was a giant GU Oncology ASCO this year. We have had some big ones in recent years with people getting into the plenary, which is the big auditorium session, and reading out, practice-changing results. But would it be fair to say it didn't seem like that? There weren't any, standing ovations when the Kaplan Myers of GU go up at this meeting?
No, it wasn't quite that sort of dramatic, I would say. That we did make progress in certain specific key areas, and definitely, we're advancing the science, but I think you're right. There was not things that I think that I would, change immediately what I do tomorrow when I go back to clinic. So but it does, help us to continue the care.
Super.
Absolutely. Let's maybe
he's
go
got a
through
list.
some.
He's got a list,
Yeah,
which
he's
is
done
great.
some of the work for us.
I love it.
Yeah.
It's fantastic. There you go, Renu. Let's get some headlines. So get ready, folks, as you're listening to your podcast on the way to work or out for a run. Or
ASCO highlights.
ASCO highlights. Here they come.
So Marty, Charted 2.
Yeah,
that's a big one.
It was, and it sort of built off the original Charted trial, which was in metastatic hormone-sensitive prostate cancer that used the combination of androgen deprivation plus docetaxel, and we know that had a mortality benefit. But the goal of Charted 2 was to look at what happens when patients develop castrate resistance. Mm-hmm. And we know that the RPs, or the androgen receptor pathway inhibitors, are great drugs for that scenario, but can we augment the response and maybe get better outcomes by combining abiraterone acetate with cabazitaxel? And so that was the purpose of the study. And it was a combined effort across many sites in the US. And it did show that there was an improvement in progression-free survival with that combination, and that it was a phase 2. So we didn't really expect there to be a large change in survival, but there did appear to be some people who benefited.
Yes, and how do you translate that into practice then, Marty? I mean, do you then prefer more sequencing of these drugs in MCRPC?
I do. I tend to not give things like that combination unless I have sort of true data that shows that it is better in something like overall survival. While we do have data from sort of the combination in hormone-sensitive disease with docetaxel, I'm a little reticent to use another taxane right after a taxane, sort of going chemo after chemo. I'm not exactly sure that that's the best strategy for everyone, and especially this high-risk group who had just progressed on a chemotherapy within a short amount of time. It's something that can be, maybe a more select population that is identified after with further studies to really know who benefits from that chemo after chemo strategy.
And it's important to have these, results out there because, I mean, you can also minimize some of the toxicities of these medications when you don't give it in combination.
Exactly right. And that there wasn't a large change in the toxicity that you would expect, from cabazitaxel alone. I think that the toxicities were mainly driven by the cabazitaxel, the more chemotherapy-like. But, that I don't really feel the need for synergy unless you're really going to sort of augment the response much more than you'd expect from a single agent.
So cabazitaxel sort of stays at the back for progressive third-line-ish MCRPC, not leaping forward in even combinations by the look of it.
Yes, I think so. And, I don't think that we're actually in this situation very often anymore anyway, because we're using the RPs in the hormone sensitive space. And so that's the other sort of limitation of this trial is that usually people have already seen an RP by the time they get to castrate resistance these days. So therefore, starting an RP at that time or using that combination is probably not something that will be commonly used because most people will have already been on the therapy when they develop castrate resistance.
Good.
Fantastic.
Charted 2 tick.
Charted 2 tick. Cyclone 2, Marty.
So, Cyclone 2 was a study of the combination of abemaciclib, which is a cyclin 4/6 inhibitor, We know it well from breast cancer, where it has had quite a bit of difference in metastatic breast cancer, and that abemaciclib was shown to have an overall survival benefit in that population. But we wanted to know in castrate-resistant prostate cancer whether or not that it would provide benefit to patients. And unfortunately, this was a trial that did not meet its primary endpoint, did not improve progression-free survival or overall survival. So the application or the use of abemaciclib is unlikely to be, progressing in at least the near future without some other way to really identify patients who really had a major benefit.
And what was the thinking behind trying this drug in prostate cancer?
Right. Well, we are aware that prostate cancer is a predominantly hormonal-driven tumor, and that in breast cancer, which is also hormonally driven, that we can add abemaciclib or use abemaciclib with hormone therapy. So the thought that, well, maybe this would be a way to either restore hormone sensitivity or that it would have activity when hormone therapy is no longer the way in which the tumors are growing. And that was sort of the concept, and just didn't quite play out as the investigators and how we all would have liked. It would have been wonderful for abemaciclib to be available for MCRPC.
Fantastic. So there we go. No benefit at this point in time of adding abemaciclib in MCRPC.
And it's important, I suppose, to say, right, that's two kind of negative trials, but it's very important that negative trials get exposed at big meetings. So we learn from that, and we're always grateful to investigators and patients who've participated. But, not everything's a winner, is it? And it's very important for informing what you do next. So, yeah,
that's
another
right,
tick.
Exactly. This next one's interesting. Metformin, the long-standing debate about, does metformin really reduce risk in prostate cancer?
Do you get asked that question?
Sometimes.
I do. And, patients will often come in and
have
say,
read something.
What about metformin? Yeah. These are patients who are not diabetic, they're not on this drug, but there's a fair bit out there when patients start doing a bit of research themselves to say, what about metformin, a cheap and cheerful thing that you can get all over the place? And I've been asked many times over the years to consider prescribing metformin, and I've always said I don't think it should only be done in a clinical trial, and I'm not going to prescribe it. But so here's the MAST study. So tell us about that.
Yes, as I also have had similar experiences where people have heard about the benefits of metformin, and in many retrospective analyses, which are not as controlled, there's been thoughts that metformin actually does have a anti-cancer effect. And so that's why this trial is so key, to actually randomize patients who have earlier stage prostate cancer in the low risk setting, sort of an active surveillance population, to metformin or not, to see if there's actually a change in the progression or a difference in the outcomes. And unfortunately, it was not shown to have any benefit. And there actually were some possible signs of harm in the metformin population. So in its current iteration, that metformin was not something that would benefit people in the low risk prostate cancer situation.
I'm having a deja vu. Wasn't there another paper in the last year or two where they took active surveillance patients who don't need treatment and gave them some actually very so drug like enzalutamide?
Do you remember that episode? I think you might have fainted halfway through.
Do not enact. And look, for us urologists who feel very passionately that we need to protect patients from overtreatment, most of us will feel very strongly that we know low-risk prostate cancer. We know that it's safe with correctly selected patients who are being correctly monitored, to do nothing. Please stop trying would be my message now, without knowing the detail of this, but maybe that's another lesson in there. Please stop trying. Just better select patients and do nothing to them, please.
And the potential harm, again, that's an important thing to point out, isn't it? That, not only are you not doing any good, but you may be doing harm. So that's definitely one to cross off the list.
Great.
Well, and also, I'm a retrospective researcher, which we may talk about later, but you should take your retrospective research with a grain of salt.
Yeah, exactly. And that unfortunately does make it out into blogs and stuff like that as well. Tick, MAST. Okay, negative. Any
familiar territory. Pluvicto. Okay. Pluvicto quality of life. That's interesting. And we've had indications of this from the trials done here and therapy. But quality of life with Pluvicto versus an ARPI switch.
Yes. And so, in multiple areas of quality of life in the PSMA4 data. So this was using PSMA 4 trial, which was shown in a pre-chemotherapy population, that patients were randomized to either Pluvicto or the RP switch. So if they were on abiraterone, they went to enzalutamide, or vice versa, that specific measures of quality of life were improved. Things like pain progression and other measures like fatigue seem to be improved with Pluvicto compared to RP switch. Now, of course, that's something that is debatable, whether that is the most appropriate control arm for this trial. And that was something that was actively debated in the room, which has been every single time that PSMA4 has been presented. But it does show that there is efficacy of this agent in the MCRPC situation, and does seem to provide benefit to patients.
And it's, I mean, that's something that's been evident from the start, isn't it, Declan? Even in the pilot phase 2 study that Michael Hoffman led, the significant improvement in quality of life just after 1 or 2 cycles.
Yeah, and then in the therapy study, which was randomized for lutetium PSMA versus cabazitaxel, again, there was no overall survival benefit in that study, but the quality of life benefit was obvious. And if you're a patient and you've got these options in front of you and you have access to lutetium, it's kind of a no-brainer when you see the quality of life stuff. And so this is, again, further reassurance, no great surprise for us with lutetium PSMA. So that's a good one, Marty.
That's good to hear, Marty. MANCAN2.
MANCAN2, that sounds like a good acronym.
Right. No, it was an impressive trial of actually doing cognitive behavioral therapy for men with symptoms on ADT. And I know that your GU cast has been, out there talking about the difficulties of living with ADT, and you had guests that sort of discussed it on his book, Patty and the Shark, but it's difficult to deal with. And that the cognitive behavioral therapy was shown to be beneficial compared to no treatment while the patient was getting the cognitive right after they had the cognitive behavioral therapy at a 6-week time point. Unfortunately, once the therapy stopped and they remeasured at 6 months, there was really no difference. And so the therapy was successful, but not necessarily sustained in longer duration of benefit.
Right. So initially useful, but
works when you're
once it stops. That's interesting.
What's the solution then? Does that mean you have to persist with the cognitive behavioral therapy? And I suppose that might be not practical or affordable, or
that, or I wonder if the behaviors and practices that the cognitive that are taught, that people can hopefully continue that even further, being able to do it on their own. I know that exercise and other interventions can hopefully be helpful for a longer term. Just unfortunately, it is hard to maintain anything for a longer duration of time.
Which I think is why, Tim Baker's acronym of MEDS, meditation, exercise, diet, sleep, is probably so important in men with ADT. Exactly. Then things that you can kind of implement in your life on an ongoing basis. So I think it highlights the importance of that.
And good to see research happening in the quality of life area on men on ADT.
Definitely.
It's an ongoing unmet need area, and we are going to continue focusing on it as well. Any more prostate cancer?
Well, EMBARK, that's EMBARK Quality of Life, in keeping with the theme of quality of life studies, which we're always happy to see. And EMBARK has, created a lot of interest. This is the use of Enza alone or Enza plus ADT in men with biochemical recurrence early on. And what do they find, Marty?
Well, this analysis that was presented by Dr. Friedland was really of the group that met the PSA goal in the EMBARK trial and therefore had their therapy stopped, and that they wanted to look to see if their symptoms improved, and that there were fewer ADT type symptoms than those that had cessation. And unfortunately, there was really not much difference, or not a drastic improvement, once the therapy was stopped. And this does, originally this was sort of something that I was surprised by, but then it was highlighted that there was not a huge decrement in symptoms when the therapy was started either. So that, and unfortunately, when in trials that, probably the more important thing that the trial was trying to show was, is there any decrement in quality of life with this more aggressive therapy? And the original trials did not show that, but then there's unlikely to be an improvement then when the therapy stops using the measurements that in this trial.
And do they do any sub-analysis on the people that did have the greatest amount of decrement at the start? And did they show that at least in those people, did things improve?
I don't remember if that was something that changed. I think that there were a certain intensity of vasomotor symptoms, but to be honest, I don't exactly remember if there was any difference.
Yeah.
We haven't really dived into the EMBARK study, and it's had the big oncological outcome paper in New England Journal of Medicine and a quality of life one after ESMO last year. And I spoke to Steve Freeland about it, and she's hopefully coming to Australia sometime in the next few months. But we need to dedicate a full episode to that, because this area of high-risk BCR is something we as urologists obviously see all the time.
Yeah.
And I think we need to understand a little bit better the role of enzalutamide in that setting. So
absolutely.
So thanks very much, Marty. Before we talk about some work you presented from the VA, which got a lot of attention, which we were very happy to see, from here in Australia, the therapy team, Ed Kwan and co did present a poster on the ctDNA work that's now emerging out of the therapy study. So I know Ed was there, and Alex Wyatt and Arun Azad from here in Melbourne as well. So yeah, did you notice that one?
I did, and actually I got to talk to Ed about his poster, and it was actually even previewed at the oral session because of its similarity with another presentation. And it was a study of patients on therapy that looking at the baseline ctDNA fraction of the patients who either got Pluvicto or they got cabazitaxel. And it was highlighted that the patients that had the lowest ctDNA fraction seemed to have the greatest benefit with Pluvicto, and there was no sort of similar difference in the cabazitaxel group, possibly highlighting that is the group that could be targeted for Pluvicto that would have the greatest benefit. There were some other correlatives as well, though, that the patients with the lowest ctDNA fraction also had the lowest mean tumor volume on imaging, but surprisingly also had, I think, the highest SUVs. So there are ways to possibly identify these patients that have possibly the best outcomes, longest progression-free survival, using ctDNA as well as other measures that we can get from imaging.
Oh, that's really nice. I mean, because it ties in very nicely with the biomarker studies that have occurred as a result of therapy that James Buteau led and was published in Lancet Oncology, that showed that the patients that benefit the most from lutetium PSMA are those with the highest SUV mean, so the highest tumor volume on PSMA PET, and the lowest tumor volume on FDG PET. So if that correlates with ctDNA fraction, then that's a nice little tie-in, isn't it? Yeah.
So you've got imaging biomarkers coming out of therapy, and that was Lancet Oncology, James Buteau's paper, and now these liquid biopsy type biomarkers. So it's really great when you see these cooperative-led studies, that one led by ANZ up here in Australia, yielding not just the clinical endpoints, but a treasure trove of imaging biomarker studies, and now ctDNA studies coming out of this. So yeah, we look forward. It only got a poster. That seemed a bit weird. I saw a few people on Twitter calling that out, Marty, to say, hang on, this is a beautiful bit of translational work from an important study. It probably should have got on the oral stage, should it not? Or is that just been a bit parochial, me and Renu?
Well, I mean, I think it has definite potential to be able to use as a biomarker. And so, it, was a phase 2 and it was small. Some of the other ctDNA studies were larger that were, given orals. But things that have great potential, I think, should have great opportunity at conferences. Yeah,
absolutely.
Although not everyone has the Alex Wyatt lab to be doing the work. And it is, and I heard him doing a podcast the other day talking about that. But yeah. Super work.
And then tell us about your poster, because that's really interesting. I mean, and this is PCF funded work. Again, sort of trying to answer a question where we really don't have the data. And this is in the metastatic hormone sensitive prostate cancer space, Marty.
Right. Yeah. There's not ever been a head-to-head trial comparing the combination therapy of ADT plus docetaxel versus ADT plus an RP like abiraterone or enzalutamide. And so we looked in the Veterans Affairs data set where we have thousands of men who've been treated in this situation. And in addition to identifying de novo metastatic hormone sensitive prostate cancer, which is the slightly higher risk, we also broke patients down into the high volume category or low volume based off of charted criteria. So it's thought that the high volume patients would benefit the most from the chemotherapy approach. And what we found that there was just no difference in overall survival in the 1,000 patients or 1,200 patients that we identified, that overall survival was exactly the same in both groups. And actually, when we look at a measure of real world progression-free survival, which was time to either castration resistance or time to death, there actually was a longer time in the RP group, that the patients who got docetaxel had a shorter time to castration resistance or death. This really happened though after 12 months, that the risk was rather similar in the first 12 months, which you would expect because docetaxel is only given for 6 cycles. And so it's about 6 months of therapy. But then as the effect of the drug wears off, there's more patients who become castration resistant. And at that point, they likely then start an RP, which is really probably affecting their overall survival because it is more of a sequencing question at that point.
Very interesting.
Yeah, nice bit of work. Congratulations, Marty. And the VA system does produce some really nice opportunities, doesn't it? And your patients are always very keen to participate. The VA system itself supports that type of work through the DoD, I think. It's and I know that that's predominantly your workplace. You really enjoy working there and doing this type of research work out of the VA as well.
Well, definitely. That it's a wonderful to be able to work with veterans. And I was in the Navy myself, and so I sort of feel a little bit of a kinship. But we're hoping to answer questions that other groups may not be able to due to the size, and especially patients with more comorbid disease. And because we're our own insurance company, we pay for all our own medicines. It does reduce a lot of barriers and put most of our treatments on a more equal footing.
Very nice. Now we always talk a lot about prostate cancer, but we should cover some of the kidney and bladder stuff that got a special mention from Marty. What have we got first on the list? That's nutrition in cystectomy.
Oh yeah, that's a good one.
That's an interesting one.
Immune enhancing nutrition in cystectomy. Yeah, that sounds like a good
bit
thing
of an
to do.
underpowered study.
Yeah.
Yes, it was a little bit underpowered, but the goal was, this was in part of the kidney and bladder oral session is, there's an idea that, the immune system, of course, plays a big role in tumor biology, and that, around the period of cystectomy, maybe by giving patients, an enhanced diet that can, really focus on helping the patient sort of recover and also prevent adverse events, that maybe the diet could have fewer adverse events in the perioperative period. Unfortunately, there was no major difference in sort of most of the operative outcomes and sort of short-term outcomes that were measured. And there hadn't been a lot of follow-up from the trial yet. So maybe in a longer term that the nutrition can sort of change the milieu and change the response. But at least in the short term, there was not a large effect that was noticed.
Very interesting. It will be interesting to see the long-term outcomes of that because, like you say, the changes that occur with diet will take ages to really be more pronounced. And we may not see anything in that perioperative, immediate post-operative period.
Still really important because of the morbidity of cystectomy as well, isn't
exactly.
it? Yeah. So please keep up this good work. And we've got 2 more to go, I think, unless Marty has thought of anything else afterwards. EV Pembro, of course, massive paper from last year. Now, that was the one that got the standing ovation at ESMO for Tom Powell's. And, that's still reverberations as that's becoming available. Right. Huge change in practice. But what else did you learn from EV Pembro?
Right. And so, we had been sort of waiting and expecting data related to some of the patient-reported outcomes and quality of life data from EV 302. And of course, we didn't disappoint. This is on the sort of, not quite the biggest stage, but at our oral session, Dr. Gupta did present how that the time to pain progression was longer with the EV02 regimen of Pembro as well as enfortumab vedotin, in comparison to the traditional sort of cisplatin-based chemotherapy. And so it did show that the agent does not have at least a large amount of toxicity, because there is some concern that the EV the duration of therapy of the enfortumab vedotin could cause more pain and actually more neuropathy, and that didn't play out, at least in this study, showing that there was still quite a bit of benefit in EV-302.
It's interesting. I think looking at these very targeted therapies, it's always quite fascinating to see the toxicity profile and the quality of life profile from these, and just like lutetium PSMA.
And is there going to be a sting in the tail that's going to mean, okay, maybe we have to look at the patient selection a bit better, even though there's some big oncological outcome, but maybe we'll invite Shilpa Gupta to come and chat.
Yeah,
we'd love to have her on the
podcast.
Maybe when this paper comes out. But again, I think it sort of reinforces the practice-changing nature of that study in the first-line setting for metastatic urothelial cancer. And we had Enrique Grande on talking about it.
That's right. Andrew Reichard.
And in fact, at our tumour board this morning, we had representatives from Astellas in there. So we were asking about the pathway here in Australia. So we're hoping we'll get an approval very soon for that and early access program. So
that'll be huge.
Really huge. Nearly there, Renu.
Yeah, Javelin 101, Marty.
Yes, and so this was another trial that caught my eye. The Javelin renal trial was using immunotherapy-based approach to sort of hopefully change the natural history of kidney cancer. This was the sort of overall survival endpoint that was trying to be reported after several years. Unfortunately, there was no major difference in overall survival, which, and of course, we're always looking for that. We're always hoping that immunotherapy is going to be a home run. I think in this situation, what could have happened was that, patients would have gotten IO therapy later or, later in the journey if they progress. And so maybe this sort of the earlier use of immunotherapy didn't really change things for the long term because patients could get the immunotherapy later. And so it is a trial that, though, as we had sort of discussed, actually does inform practice and, tells us, about, how we should possibly sequence our therapies.
Yeah, sequencing it therapy is so important.
I love it. What a great summary, Marty.
Yeah,
Can we get on more often? We can just,
we can stop going to meetings.
Yeah,
just send Marty along.
Exactly. Send Marty.
So Marty, you're all inspired by this huge ASCO meeting. What are your plans in the immediate future? Have you got any ideas for research and collaborations?
Oh, definitely. I think that the era of precision oncology is it's here, but we need to even be better about it. We need to use the tumor as well as the patient features to be able to combine to really figure out who benefits, not just to add therapies, but then also to possibly take them away to de-escalate. And that's what I'm hoping that we will continue to do.
He said all the buzzwords.
Indeed.
It's very good.
Yeah.
Well,
do we need to go to ASCO any in the future? I don't think we just, again, he didn't stand up and say there was a fantastic video about doing pelvic lymph node dissection in the salvage setting with PSMA radio-guided surgery.
There was no debate this time.
No, sounds like there was a lot of Kaplan-Meiers. There was quite a lot of them that had very little difference between the curves. So I think you were better off in Malaysia. I was better off at home here in Melbourne. So,
but we did get a fantastic update from Marty.
Yeah.
So we're very grateful, Marty. Thank you for supporting us at GU Cast and for going to ASCO for us.
Glad to be helped. Glad to sort of continue education. Such a wonderful podcast. I'm honored to be a part of it.
And we're also very humble that you got rid of your usual bow tie, which is your trademark.
He is. He's always.
It is his trademark, and he's swapped it for a GU Cast shirt.
No, I want to represent and. I felt like it was part of the theme. I actually thought that you both would be wearing it as well. That we could all be three peas in a pod.
Yeah, and we're kind of working today. You're operating in the afternoon, and I've been consulting.
But we thought we wanted to give you a chance to shine in the merchandise.
And I think even though he's got pre-access to the merch, we need to get Katie to send him out a goodie pack as well.
Absolutely.
Super.
Thank you, Marty.
Thank you very much to Marty. Thank you all for listening. Please, as ever, get in touch if there's something you'd like us to cover. Please do subscribe and rate and review and all that. And thanks very much, as ever, to all the partners who support us doing this podcast. And We'll be back
see you
soon
next
again.
time.
What have we got coming up? We got some good ones coming. We still haven't finalized the APCCC podcast. It will come out next week, and they'll be worth a watch. They're quite good.
We've got a fantastic one coming up on the EAU guidelines. I'm really looking forward to that. We haven't even recorded it yet. That'll be a job for tomorrow morning, early in the morning.
Prostate cancer. You know what changed? What's controversial? So we're looking forward to that, and we'll be back real soon again.
Definitely.
That's it from us.